Bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities:
All right, hello everyone, and welcome to today's webinar. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today's webinar is titled Defining the Rate of Heavy Fetal Alcohol Exposure in Canada, a National Study. But before we get to the presentation, I just want to make sure that, as always, that everyone is familiar with our webinar process. As always, we do take questions throughout the webinar, so at any time you think of a question, please type it in as you think about it. Don't feel you need to wait until we call for questions or anything like that. Just type them in as you think about it, as we will be taking questions very likely throughout the presentation today. You're free to come in and out of the session, as this doesn't interrupt the session, and we do record the entire webinar, so you can always go back to the recording to catch up on any parts that you might have missed. The recording and any other resources are posted, as always, on the CAFC Knowledge Exchange Network at www.ken.cafc.org. It usually takes a couple of days to get that information up, and you will receive, the person who's registered their email address for this will receive an automated message from the system with a direct link to the page where you can find the full audio-visual recording as well as any other resources that may be provided to us by our presenters. The CAN does also provide comments for registered users. Registering an account on the CAN is free and open to anyone, so please go ahead and do that at any time and join us in the discussion following the presentation. If you have comments or questions or additional information or supplemental information that you think you'd like to contribute to the discussion, then please do that on the Knowledge Exchange Network. So again, it's as last week. For those of you who joined us last week, it's once again my pleasure to introduce some folks who are becoming more and more familiar to the CAFC audience, as this is, I think, might be the third or fourth or fifth time for some of the presenters that we have today. And again, we're continuing the discussions on the development of screening tools for fetal alcohol spectrum disorder. And this is part of CAFC's work on developing a toolkit for screening for fetal alcohol spectrum disorder. And we always want to recognize the partnership and our funder, the Public Health Agency of Canada, and thank them for their tremendous and ongoing support for this work around screening tools for fetal alcohol spectrum disorder. Today's topic is specifically focused on the component of our toolkit around meconium screening, and we have had a number of webinars on the meconium screening tool, from the basics to the ethics of the tool to a number of other angles looking at this specific tool, this very interesting tool. So please do go to the Knowledge Exchange Network and check out any of those other presentations that you might be able to find there. And before I introduce our speakers, I'd also like to recognize, as I did last week, but for anyone who wasn't there, I'd just like to recognize Charlotte Rosenbaum, who is the project manager who, at least on the webinars, was always behind the scenes for some of the developmental work of this screening toolkit. She was always very much front and center, and Charlotte announced her retirement, and we'd just like to thank and recognize her work for the last, I think, 7 years or so, and her contributions to this work, which is incredible, and she's really the one who cracked the whip and kept everyone on track, and was a big part of making all of this happen. So we wish Charlotte well in her retirement, and hopefully I'm sure she'll enjoy it. So now it's my pleasure to, once again, as I mentioned, welcome back some very familiar names. I'm going to introduce Dr. Gideon Koren, who's a pediatrician at the Hospital for Sick Children and the founder and the director of the Motherisk Program. And he's also a professor of pediatrics, pharmacology, and medicine at the University of Toronto. And Dr. Koren is also a member of the CAFC FASD Screening Tools Steering Committee, and he's sort of going to lead us into this discussion on defining the rate, the national study to define the rate of heavy exposure to fetal alcohol exposure in Canada. So my pleasure to hand the virtual podium over to you, Dr. Koren.
Thank you very much, Doug. I would say good morning and actually good afternoon, depends where you are, this large country. It's with pleasure that we will introduce to you an area that I believe Canada is leading the world. We all know that we have a huge issue when it comes to alcohol in pregnancy. But for many years, we didn't know the size of the issue because we didn't have a good marker for it. Of course, you can try to talk to mom and find out, as we should all, about her drinking. Unfortunately, there are many reasons why this source of report may not be accurate and will minimize the rates that are reported, including fear, embarrassment, fear of losing custody of children. So while these kids will be affected very often lifelong, with huge costs to Canada and other countries as well, we really do not know the size of the issue. We probably see the tip of an iceberg. We were lucky to be in the forefront of this research starting almost 16 years ago, when we began to look for ways that obviate the need for history. And that can be used as a tool, an epidemiological tool, as well as singular tool per patient. And these will be introduced to you in a couple of minutes by my colleagues. So the Meconium, as you will hear from my colleague Joey Guerreri, the first fecal excretion of the baby is a bank that has memory, an account of how much alcohol was seen by the baby. We do not measure alcohol directly, but one of its metabolites. And with the support of the Public Health Agency of Canada, which really was the first agency worldwide to develop those tools for screening and prevention, we were very fortunate over the last 7 or 8 years to move our basic research here in Toronto into the sphere of public health in Canada, coast to coast. And that will be the forum we will discuss today. We hope to be able to tell you how well it works, how effective it is, some of the potential pitfalls, and of course, most importantly, how are we going to use it diagnostically? It has been already approved as part of the toolkit by PHAC, which we developed as one of the tools that can allow us to identify positively kids who were exposed heavily to alcohol during fetal life. Joey Guerreri, who will start this, actually was involved quite early when we did the first Ontario study in GreyBruce. This was Joey's master's thesis. Since then, he became a staff member of the Motherisk team, the lab manager, and actually Joey is just about to complete his PhD studies and stay faculty with us while he is working continuously on the Meconium as a biological marker. And Joe will introduce to us the Meconium, and then he will show you some of the breakthrough studies that he was involved with that brought us to where we now can do a national study. Joe.
Thank you very much, Kitty. Good morning, everyone. I'm going to take the next 20 minutes or so to introduce you to what Meconium testing is and describe the subnational studies that have been conducted up till now. So it's a road that we've been traveling to establish incidence in larger and larger populations, culminating with the MyREC study that Caitlin Delano will be presenting after me. So I'm going to introduce a little bit of background around fetal alcohol spectrum disorder. I don't want to assume that everyone tuning into the webinar is totally familiar with why this kind of surveillance is really important. FASD is an umbrella term that describes 4 different diagnoses: fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorders, and alcohol-related birth defects. There's been a number of prevalence estimates for FASD. This isn't exposure to alcohol, but actual FASD, suggesting around a 1% general population prevalence in North America. It's been also estimated that the annual cost of FASD in Canada is over $5 billion. And there are established significant benefits to early diagnosis and intervention. While these benefits are known and have been known for almost 20 years now, we still don't have widespread programs for early diagnosis and early intervention. FAS, or fetal alcohol syndrome, is the most severe manifestation of FASD. These are the children who are most severely affected by ethanol exposure, and they're traditionally the children that are recognized as alcohol affected. These children display three characteristic craniofacial dysmorphologies: flat philtrum, which is the canal from the nose to the upper lip, a thin upper lip, and a small eye slit, which is the palpebral fissure. The problem with these craniofacial features is that they're only present in 10% of affected individuals. So the children that are most severely delayed and are easily recognizable represent a minority of the children that actually have the whole population of children with neurodevelopmental deficits. The true challenge with FASD is that while not all the patients display the physical features of the disease, all of them show substantial deficits in multiple areas of neurobehavioral functioning. And these deficits lead to difficulty in acquisition of information, comprehension of information, visual attention, shifting attention, cognitive flexibility, response inhibition, leading to impulsive behaviors, and a lack of understanding of consequences, which renders many of these individuals to have behavioral challenges and a lot of trouble in school environments. Planning and concept formation and reasoning. These are the higher level functions that are impaired because of the structural deficits caused by alcohol in the developing brain. So all of these impairments have a root in neuroscience and a root in damaged structures that were developing prenatally. The secondary disabilities is the area of prevention that we really focus on. While these children will have deficits in their brain functioning that can never be fully overcome, with early intervention, the deficits can be mitigated somewhat, but we can substantially prevent secondary disabilities. These are life outcomes that are a result of unrecognized deficits in neurobehavioral functioning. So these children that are unrecognized to have brain damage will be labeled as problematic in schools and experience disrupted school experience, often not receiving educational supports they require because their cognitive deficits are not fully understood. Many of them will have increased interaction with the law, and in fact, studies in Canadian federal penitentiaries have estimated between 25 to 50% incidence of FASD in some prison populations in Canada. There are very high rates in this population of unemployment and dependent living, inappropriate or promiscuous sexual behavior, and very high rates of mental health problems and substance addiction, which leads to an intergenerational aspect of FASD, with affected individuals being at a high risk to develop alcohol use issues and unplanned pregnancies. These are the areas that are highly preventable. So identifying children before the age of 6 is shown to be protective against these secondary disabilities and have the capacity to substantially improve life outcomes for these kids. I want to reiterate that 90% of alcohol-affected children appear physically normal. They are not distinguishable in a crowd, and their developmental delays from an IQ standpoint actually don't put them out of the population norms. So they appear to function well, but they have impairments in higher level executive functioning that affects their ability to interact effectively with society and to move forward. Another key piece of information is that having evidence of significant prenatal exposure to alcohol is a requirement for diagnosis in children that don't have any of the physical features of the disease. So 9 out of 10 times there's a child with a brain deficit from prenatal alcohol exposure. We're relying in part upon knowing that they were alcohol exposed to give them a diagnosis and to fully understand the nature of their cognitive issues, which may be mislabeled as attention deficit hyperactivity disorder or autism. So I'll move on to detecting heavy gestational alcohol use now that I've talked about how important it is to have that information. We assume Canadian women know not to drink in pregnancy, right? Well, there's been a lot of strong public health messaging over the last 30 years. It's been somewhat reversed lately with discussion about low levels of alcohol and a lot of debate in that area. So I would argue that now, even more than 10 years ago, it's more important to have accurate measures of alcohol consumption. Because as we know with all public health measures, when low levels of use increase in a population, high levels of use will also substantially increase. Dr. Koren alluded to barriers to self-report in the healthcare system for prenatal alcohol exposure. And I'd like to talk a little bit more in detail about that. Why wouldn't pregnant women disclose prenatal alcohol use? Well, it's not all on the pregnant women. There's actually a substantial lack of knowledge in healthcare practitioners, in physicians, family physicians, and obstetricians about not only the effects of alcohol in pregnancy, but how to effectively ask questions about alcohol use. Practitioners are uncomfortable asking about alcohol use. So many of them have concerns about patient responses. They might have personal issues about alcohol use and are very unsure as to how to ask women. They don't know exactly what to do with the information if they have a woman who's 4 or 5 months pregnant that discloses to them that she's drinking heavily. And we in the healthcare system haven't provided an avenue for these physicians either, an easy avenue to deal with that. They're also unsure how to advise women. They're often unaware of services for women who are having difficulty changing drinking behavior in pregnancy. And there's often improper use of appropriate screening tools. What this means is they'll often use open-ended questions that fail to distinguish between problem and non-problem drinkers. The classic example is asking someone, do you drink? Or asking a pregnant woman, you're not drinking now that you're pregnant, are you? Asking it in an open-ended manner with a little bit of sort of prejudgment on what the response is going to be, which will always elicit a negative answer. There are many older, well-known tools for obtaining accurate alcohol use histories, but many of those were designed for male alcohol treatment patients and not validated in women or in pregnant women, which is a distinctly different patient population. Urine testing is another routinely available means to find out about alcohol use, but alcohol is eliminated very quickly out of the body. 1 drink of alcohol contains about 14 grams of pure ethanol, and that's the same amount of total alcohol that's in a bottle of beer, a glass of wine, or a shot of liquor. Our bodies eliminate alcohol at a rate of about a half a drink to a drink an hour. So, of course, slightly variable between people. But this means that a urine test for alcohol will only detect alcohol use within about 12 hours of exposure. So a physician getting a urine test positive for alcohol in a pregnant woman or a newborn is only identifying women that were drinking and babies that were exposed within the last 12 to 24 hours maximum. I'll move on now to meconium testing, which is, as you'll see through the last half of my presentation, has proven quite effective in answering these types of questions about population-level alcohol exposure. Meconium starts to form in the fetal intestine at about the 12th week of pregnancy, at the time when fetal swallowing begins. It's at this time the fetus begins to swallow amniotic fluid. This means that meconium testing excludes exposures during the first trimester of pregnancy, and I'll come back to that a little bit later. There are some advantages in testing meconium. It's a discarded material, and the collection is easy and non-invasive, so it's beneficial that it doesn't require a needle prick on a newborn or collection of any blood, as well as urine collection in a newborn can be quite challenging. What are FAEE? So bear with me on this slide. I promise I won't test you on it later. You'll see here that when ethanol goes into the body, it follows multiple different pathways to elimination. The majority of ethanol is burned off and converted into carbon dioxide and water. The ethanol that is tested, or ethanol is the type of alcohol we drink, that's eliminated unchanged is the ethanol that's detected in breath through breathalyzers and in urine. So these unchanged ethanol has very short-lived and has a very short detection window, like I said earlier. What we're looking at are fatty acid ethyl esters, which are formed from ethanol combining with free fatty acids in the body. And they have a longer duration of existence in the blood. They take a longer time to be eliminated, and they have more time to incorporate into meconium. So they're very stable compounds, and we can detect them long after exposures are over. So in essence, when we're testing meconium, what we're looking at is alcohol that was drank by the mother, crosses the placenta, combines with fatty acids in the baby, and then is deposited in the meconium of the newborn. FAE meconium testing has been extensively validated, starting in the late 90s. It correlates with about 2 standard drinks per drinking day. This is an estimate of the level of drinking associated with positive meconium FAE results. A positive cutoff was determined because our bodies naturally produce very small amounts of ethyl alcohol, and so we naturally produce small amounts of FAEE. These small amounts of alcohol are produced as a natural byproduct of digestion. It was also determined that FAEE do not cross the placenta, leading to the model I showed you before. It's the ethanol that's already crossed into the baby that we're measuring. We're not measuring ethanol that's been metabolized by the mother and then the FAEs crossing the placenta and depositing in the baby. So the FAEE and the meconium represent alcohol metabolized by the fetus. Animal studies have also showed an inverse correlation between meconium FAE levels and fetal brain weight in guinea pigs, showing that with elevated FAEE levels in guinea pig meconium pups, they have lower brain weight, showing an association with brain damage. Moving from animal studies into human clinical studies, studies in children that have tested positive for FAE and meconium show lower APGAR scores, lower birth weight, decreased scoring on different executive functioning tasks, decreased head circumference, decreased psychomotor performance at 2 years of age, a correlation with FAS or partial FAS diagnosis at the age of 5 years, and the meconium FAE concentrations correlated much more strongly than maternal self-report with measures of recognition memory, processing speed, and complexity of symbolic play. There are optimal conditions for collecting meconium samples, so when we're conducting a study, the conditions of collection are very important for us to establish with our collection sites and our study team. The first meconium passed is the best meconium to use for analysis. Regardless, meconium collection should occur within 24 hours of birth. This is because Irene Zellner showed in 2012 that delayed sample collection can lead to false positive results due to bacterial colonization of the gut. So when babies are born, their intestines are sterile. They contain no intestinal bacteria. In the first days of life, bacteria colonize the intestine to assist in digestion, just as we all have in our intestines. And these bacteria can produce higher levels of FAEE. So optimally, one should be collecting meconium samples for FAE analysis within 24 hours of birth, ideally the first meconium sample. I'll move on now with all that, keeping all the background in mind, to our current population estimates of prenatal alcohol exposure incidence in our subnational studies. The first study we published was done in GreyBruce, Ontario, and this is a regional population where we looked at all the babies born over a one-year period within the region of GreyBruce. Of 682 samples we tested, 17 tested positive, giving us a fetal alcohol exposure rate of 2.5% in this population. Importantly, and what we're doing here is really generating public health data that's more accurate about how much resources need to be allotted to addressing FASD and addressing maternal alcohol use disorders. This study was done in conjunction with the public health unit of GreyBruce, who at that point was only receiving information about alcohol and drug exposures in pregnancy through the Healthy Babies, Healthy Children program in Ontario. And if we look at the Healthy Babies, Healthy Children data from that same year, the prevalence of both drug and alcohol use obtained by self-report in routine screening was 0.5%. So meconium analysis showed greater than 5-fold higher values of problematic alcohol consumption in pregnancy than maternal self-report. I want to also emphasize, while it wasn't the primary goal of this study to look at drug use, we can assume that the rate of substance addiction is also much higher in this population, as the 2.5% was only alcohol. So this was a general population study using an anonymous study design in order to maximize participation and get the most accurate prevalence value. We moved on from this study to look at a specialized population in the neonatal intensive care unit associated with this region. Now the NICU was situated outside of the region, so we actually didn't capture any of the babies born from high-risk pregnancies in that initial sample. So we followed up the general population screen with an anonymous screening study only in the high-risk pregnancies. And following that study, we modeled a non-anonymous opt-in screening pilot offering early life follow-up services through the GreyBruce Public Health Unit. And I'll show you the results, the comparative results of these three studies. The first study in the general population had a participation rate of about 93%, with no reported refusals. Most of the lost samples were due to technicality, either the meconium was thrown away or the results were not analyzable because of the quality of the meconium specimen. When we looked at the high-risk population from this same region, we had a 10-fold increase in the rate of positivity. It was an anonymous study, so we had a very similar rate of participation. So we found in the NICU population, 10 times more babies were exposed to prenatal alcohol exposure. When we moved to an opt-in screening model with informed consent, participation dropped by about 20%, down to about 77%. And likewise, the positivity rate dropped by 90%. So once we moved to non-anonymous screening, we lost about 90% of identifying 90% of the babies that were prenatally exposed to substantial amounts of alcohol. So this shows that if we're looking at public health data, it's important to have an anonymous model. But would we consider this study to be a failure or a poor performance? I'll wrap up what we found from that study in my concluding statements. But for now, I want to focus on the population data. Moving from our regional population into a provincial study. So this was the natural progression of our work, looking at an entire provincial population of Prince Edward Island. And this study was funded by CAPC through the Public Health Agency of Canada and done in conjunction with the University of PEI School of Nursing and all the local hospitals in PEI, as well as University of Toronto and Motherisk. This study is currently in press and has been accepted for publication in CMAJ Open. So we moved from studying a regional population to an entire province and found a fetal alcohol exposure rate of between 3 and 4.4%. This variability is because not all the samples were collected in the first 24 hours. And Caitlin will talk a little bit more about that, how we calculate ranges of prevalence in her study. We tested over 1,200 babies born over a one-year period in PEI and found between 39 to 56 samples positive. To compare again to standard public health data that's gathered through the reproductive care program in the province, in 2011, self-reports, and this is anonymous self-reports, had less than 1% incidence of alcohol use in pregnancy. So we found 3 to 4-fold higher than self-reported values based on meconium analysis. And in fact, earlier this month, a study was published by Lang et al. Comparing self-reported versus meconium fetal alcohol exposure prevalence data. They conducted a systematic literature review, which included the 2 studies I previously discussed with you, but also a number of international studies that have done the same thing, looking at fetal alcohol exposure prevalence in Germany, Italy, and Spain, as well as in Uruguay, compared against maternal self-report data. And overall, meconium tends to determine prevalence estimates over 4 times higher than maternal self-report. Now you'll see here that in certain populations where alcohol use in pregnancy might be less stigmatized or there might be less awareness about the issues of alcohol use in pregnancy. For example, there's this Italian population and this population in Uruguay where self-report is pretty accurate. But once we move into better developed public health areas where women are not using alcohol in pregnancy, as that behavior becomes stigmatized, self-report becomes less and less reliable. So I'm going to close out with some closing thoughts. It's important to recognize that traditional means of public health data gathering are really not optimized for highly stigmatized behavior. So anonymous questionnaires don't detect things like drug and alcohol use in pregnancy very effectively. It is expected that approximately 40% of exposed babies, prenatally exposed to alcohol, will have FASD. Meconium-based estimates are also likely to be conservative in predicting population FASD risk. So while meconium estimates are often 4 times higher than self-report estimates, it's important to note that first trimester exposures are totally excluded from meconium. Meconium testing also exhibits a sensitivity of approximately 80% is estimated. So there's going to be some meconium negatives from women that were still drinking in pregnancy. And this is true with any screening test. Positivity is also associated with drinking greater than 7 drinks a week, about 2 drinks a day. And this level may be higher than the threshold for developing FASD. So you can have children that are negative on meconium whose moms maybe drank less frequently but binge consumed 3 or 4 times in the pregnancy large amounts of alcohol that could cause substantial damage, but is not enough to cause a positive meconium result. So it's important to keep in mind meconium numbers are not necessarily the ceiling for fetal alcohol exposure. Different populations will exhibit different rates of prenatal alcohol exposure, which is why there's such a need for a Canada-wide estimate. Meconium testing does show promise as a neonatal screening tool. And this is the opt-in model screening study by Zellner, published in 2012, really showed us that even though we lost 90% of the alcohol-exposed babies, we still identified one child in just under 30 pregnancies, which is a positivity rate of 3%, that was positive. And this child actually required early intervention services and showed deficits early in life. This is actually a remarkably good performance for a screening tool. And while this doesn't establish the success rate because of this is just a pilot and a small number of women studied, when you look at this success rate, identifying 1 in 30 kids that actually needed support compared to 28 currently screened neonatal disorders in Ontario, which affect less than 0.5% of the whole population and have a false positive screening rate of about 88%. So most of the kids that screen positive for metabolic disorders ultimately don't end up having them. This is the nature of how screening works, but it's just important to recognize that even in a small pilot, we've had good success in identifying a child that required early intervention. So I'd like to thank all the individuals that made these studies possible, and I'll pass over to Dr. Koren to introduce Caitlin Delano.
Thank you very much, Joey. Doug, are there at this point any questions that Joey can answer?
No, there haven't been any questions come in yet, but that's my chance to remind the audience to type those questions in as you think of them. And even if you do have questions related to the information that Joey just presented, go ahead and type them in now, and we'll be sure to answer them at the next break.
Okay, thank you very much. Moving forward, Joey described to you several sub-Canadian studies done on particular segments of society, but it's with great pleasure that I'll introduce to you now Caitlin Delano. Caitlin is completing her PhD with my laboratory at Motherisk at SickKids as part of her degree in pharmacology at the University of Toronto. And Caitlin has been working as part of this initiative to work on the national study. I will not steal her fire to tell you how we came across the national opportunity here, but maybe it's a good example where collaboration with other Canadians can be a good idea, because other people did a lot of work that could be used by us. It was a good lesson that collaboration should be the name of the game in this country. So Caitlin will describe to you the latest phase of this country, which for the first time will give us the national rates of heavy fetal exposure to alcohol, which is important in any level, of course, from knowing the burden, from knowing where clinics will be needed, where preventative work will be needed, etc., etc. Caitlin just won 2 weeks ago the best research paper, clinical research paper at SickKids, actually forum that runs once a year. And without any delay, let me have Caitlin tell you how we calculate the prevalence coast to coast to coast.
Thank you, Dr. Koren. Good afternoon now, I think, or morning still for some of us. So I'm going to be talking about one of the projects that I've been working on for my PhD. And this is a collaboration, like Dr. Koren said, between the MIREC study and us at the Motherisk lab to try and determine the prevalence of heavy alcohol use in Canada. So So the MyREX study, just to give you some background on this study itself, we came across that there was this study that was occurring. It was a national study, nationwide, and they were actually measuring the extent of chemical exposures throughout pregnancy in the mums and the infants. And this study was actually focusing on heavy metal exposure, especially lead and mercury. Now, this was a very intensive study. There's a lot of different checkpoints throughout the study, which I'll kind of go through to give an overview. They also collected a lot of different samples. So they collected blood samples, hair samples from mom, breast milk samples. They also collected meconium samples. Now, they also did numerous questionnaires throughout the study, and there was actually a whole section on drinking habits during pregnancy in these questionnaires. Yet, the people that were involved in this study weren't analyzing anything about fetal alcohol exposure. So we found out about this. Wait, you have meconium and you have a self-report for moms. Well, why don't we try and figure out the nationwide rate of fetal alcohol exposure in Canada, because we do have samples from across Canada and we have this self-report that we can compare them to. So the MyREX study, as you can see here in this diagram, there's many different checkpoints along the progression of this study. So they recruited women around 6 to 13 weeks pregnant for their first prenatal visit, and they did maternal urine collection, blood collection. They also followed them up at 16 to 21 weeks. Again, more collection of biological samples. And they also followed up again at 32 to 34 weeks. Again, more maternal samples were collected. They also did data collection involving the delivery, so any outcomes for mom and baby. They then also collected cord blood for the babies at this time point as well. So around the postpartum day 1 or 2, they collected the meconium samples, and they tested them for the compounds listed here. Then they also did a post-delivery follow-up with the moms around 2 to 10 weeks post-delivery, and this is when they collected the maternal hair samples along with breast milk samples and did questionnaires. Where I've indicated the green check marks, this is where they performed the questionnaires that we at Motherisk had access to. And at all 3 of these questionnaires, there were questions about the drinking habits. So we have maternal self-report right at the beginning of pregnancy, right in the middle of pregnancy, which would correlate with a meconium test. So this is the one that we would be comparing to, along with one that was just post-delivery. Now, they recruited women from 11 obstetric units across 10 cities in Canada, listed here. So Vancouver, Edmonton, Winnipeg, a lot in Ontario, so Toronto, Hamilton, Sudbury, Kingston, and Ottawa, and then Montreal and Halifax. So we do have a good range of cities that are covered in this study. However, we are missing some provinces, and especially the territories. We are missing rates there, but it will give us a better overview for our study about the prevalence rates of heavy fetal alcohol exposure. So they recruited women aged 18 years or older. They did exclude any women that had any major malformations, a history of medical complications like renal disease, epilepsy, or cancer. They approached over 8,000 women. Finally, 2,000 consented. However, they did lose some of the women. Obviously, this is a very intensive study, so you are going to lose some women throughout the study just due to loss to follow-up. Throughout this, they then, once the babies were obviously delivered, they were able to collect 1,591 meconium samples. Now, we went to their biobank, which is located in Quebec, and we collected 1,537 meconium samples. This is mainly because some of them, they had already used up all the meconium available for their studies, so that's kind of how we lost that as well. Some of the women did not actually consent to participating in the Biobank program, so that's why we have a few less than what was originally collected. Now, for the questionnaires for the MyREX study, they had a wide range of questions included. So they included sociodemographic characteristics like education level, ethnicity, annual household income. They also looked at smoking history very intensively as they were measuring nicotine and cotinine in their samples, both past and present smoking habits along with secondhand smoke exposure. Like I said, they did cover alcohol consumption, so they actually broke it down into how many number of glasses of wine, beer, or liquor the women consumed during the different time points, along with the number of drinks over the past 3 months, and they also collected binging information, so how many times did they have a binging episode over the past 3 months. In terms of labor and delivery collection for data, they collected the method of delivery, any complications like maternal hemorrhage, or if the baby or the mom was needed to be transferred to another hospital. And then in terms of neonatal information, the birth weight, birth length, head circumference, along with APGAR scores and any complications for the baby were also collected, which we've also gotten access to at the Motherisk Laboratory so that we can do correlations with any neonatal or maternal outcomes with our results on the FAE analysis. Just to give you a little overview of the MIREC cohort, this was published last year. They did basically an introduction to their cohort just to introduce the public to who they were actually studying. So the mean maternal age is at 32 years approximately. They compared this to other averages for Canada. So the average mean maternal age for the population in Canada is about 29 years. A lot of the women had no previous viable pregnancy, so this was their first pregnancy. Majority were born in Canada. A large majority had a university-level degree, which is significantly higher than that's the normal rate in Canada. A very low amount were current smokers, especially significantly less than that's the average in Canada. Large proportion had a household income of greater than $60,000 per year. So we are looking at not a low socioeconomic status women in this study. So this should be noted throughout the study that there was a selection bias definitely in this MIREC study. In terms of the babies, about 8% were preterm births. They had a mean birth weight of about 3,400 grams, and only about 5.7% had a low birth weight. This just gives us a nice overview of what this cohort is and who makes up this cohort that we're looking at. So what we wanted to do at the Motherisk Lab, firstly, our primary objective was to determine the prevalence of heavy alcohol use during pregnancy in Canada. Now, we hypothesized for this study that the prevalence of heavy alcohol use during pregnancy in Canada would be in excess of 3%. As Joey had said, it's approximately 1% of all births are affected by FASD. And also, as Joey mentioned, that doesn't cover every single child. So about only 40% of the children that were exposed to heavy alcohol exposure will show an FASD or diagnosed with an FASD disorder. So that's why we came up with the excess of 3% to account for those children that are missed from a diagnosis. Now, secondary objectives that we are looking at in this study, of course, is to correlate the meconium FAE levels with the neonatal outcomes that we have. And we hypothesize that those samples with the higher levels of FAEs will result in poor neonatal outcomes. We hope that this objective will highlight some of the key features that physicians can look for in the children to maybe indicate if further investigation is needed towards if they have fetal alcohol spectrum disorder. As well, we want to compare the meconium FAE levels with the maternal reports, of course, that we got through the questionnaires. And we do hypothesize that the meconium results will identify more heavy alcohol use than the maternal self-report, as Joey had shown throughout all the other the subnational studies, that usually meconium results do predict heavy alcohol use better than self-report. So for our methods at the Motherisk Laboratory, so the MIREC study nicely already recruited all the women and did all of this data collection. So on our part, we have to analyze the meconium samples. So we do this through a GCMS analysis, and we analyze for 4 FAEs listed here. So ethyl palmitate, oleate, linoleate, and stearate. Now we analyze for all 4 of these, and we calculate a total FAE concentration. And as previously mentioned, we use a positive cutoff of 2 nanomoles per gram meconium for the FAE. So any meconium sample that has a total FAE concentration greater than 2 nanomoles per gram, that's indicated as a positive sample. In terms of data analysis, we'll be calculating the incidence of heavy ethanol exposure, both nationwide, so we have a nationwide rate, but as well we will be calculating an incidence for each individual obstetric unit so that we can possibly identify any higher risk locations across the country. And then we will be correlating between the maternal and neonatal outcome data, both for the cumulative FAE concentration and as well as the individual FAE concentration as well. Now, in terms of the maternal self-report alcohol consumption data, we will be calculating how much the women were reporting drinking during the 3 months for that the questionnaire covers, and as well we'll be corresponding that with the FAE results. I'll be going into that a little bit further of how we will be doing that. So for our preliminary results, so far 530 of the over 1,500 samples have been processed. Unfortunately, 64 of them had not sufficient quantity for analysis, and 9 of them were stool samples, so those were not eligible for analysis. So we'll show here, I broke it down into the collection time. This was available to us through the MyREX study to show when the meconium samples were actually collected. So I've broken it down by less than 24 hours, which is the ideal collection time period, 24 to 48 hours, greater than 48 hours, and then if it wasn't available, we noted it there. So we did have some positives detected, 2 of which were collected less than 24 hours. We had a lot of negatives, which is what is expected. The inconclusive samples shown here, these are transitional samples. So this is when meconium is becoming mixed with a stool sample, and these samples are associated with higher rates of false positivity. So we do have to take the results of these cautionary, and we don't actually name them a true positive because of the high risk of false positivity for these samples. So when we look at this, as Joey had said for the PEI study, and he had the range of positivity rates, this is because we determine the rates based on the collection time, so less than 24 hours or 24. So each of these would have a different positivity rate. So for this study so far, we have a range from about 0.4% up to 7.2%, and this is all depending on the collection time. However, there is another way that we can interpret these results from the meconium analysis, and this is in help with Irene Zellner's paper that was previously mentioned, where she looked at the false positivity rate for serial meconium collection and the FAE analysis. So in this graph here, we can see that approximately between 24 and 48 hours, the rate of false positivity approximately doubles. And then between 24 and 72 hours, it's approximately a tripling of the false positivity rate. So if we then take the samples that I've analyzed for this nationwide study, including the ones with the collection time unknown, and we basically halve the number of positive samples for the 24 to 48 hours, and then take 1/3 of the positive samples for the greater than 48 hours time collection grouping. It's approximately a rate of 4.112%. Now, if we don't include the samples with the unknown collection time, because we don't know where they fall within those 3 groups, it's approximately 3%. So both of these do go in line with what we are hypothesizing, but of course, as this is in process, this project, these numbers can easily change between a new batch being run as time goes on. Now, in terms of the self-report by mom, we've looked at the their self-report, and we basically looked at social level drinking and above social level drinking. Now, social level drinking, at the Motherisk Laboratory, we do sample analysis for Children's Aid Societies and hospitals, and in our interpretations, we tend to say that social level drinking for a pregnant woman would be between 1 isolated drink during pregnancy up to 1 drink per month. So then that would be, in terms of the questionnaire, if any mom reported drinking over 3 drinks over the 3 months, then that would be above social level drinking. So of all the positive samples, so any of the ones that were indicated as positive, only one mother reported above social level drinking. And we should note that the FAE test does not detect the social level drinking, which is why we can't really say, and even when we see it in the negatives, this is probably why it became a negative result, because it doesn't detect that social level drinking. Now, we will be correlating the Meconium FAE results, but we will only be doing those with the less than 24 hours, and that's really because of how we are going to be interpreting the results with the false positive results from Irene Zellner's work previously. So we don't know when we take half of the number of samples in this population, we don't know if we included these 3 or not, so we won't be doing the correlation there, so it'll solely be doing it with the less than 24 hours, and as we only have 2 samples right now, we can't do any statistics on that yet. Now as well, because we had such a high level of maternal self-report, even in the negative samples, a further objective for the study will be doing a dose-response analysis for these negative samples to see if we can actually differentiate between the social and above social level drinking. In previous studies, this hasn't been able to be found, but we possibly with the large number of samples that we're dealing with in this study, that we would be able to possibly determine a dose response in this population for FAEs in the meconium and the maternal self-report. Also, just to note, just in this population here, we had about 20% of the moms indicating that they did drink during pregnancy, and that was from the 32 to 34-week questionnaire, either social or above social level drinking. So we do have a high level of maternal self-report and a relatively low rate of positivity through meconium samples. One possible reason for that is the fact that this study was not actually looking at alcohol consumption during pregnancy, and the moms, there's probably not that stigma or the sense that there will be consequences with admitting or reporting drinking during pregnancy, so this would probably be why a lot of the moms did report it in this study. So really, I hope that I've shown you that this is truly the first national study, almost national study, on fetal alcohol exposures through the meconium analysis. And I hope that I've been able to demonstrate how really this can give us a better idea of what's going on in the country in terms of drinking during pregnancy. We hope that hopefully when our numbers do become larger that we will be able to correlate between the FAE concentrations and neonatal outcomes and really give us a better idea of potential signs at birth of heavy fetal alcohol exposure aside from the facial symptoms or signs of FASD. So hopefully we can help physicians and give them more tools to identify infants that are at risk of FASD. So with that, I just want to thank my supervisor, Dr. Koren, along with all the people in the Motherisk Laboratory, along with the MyRIP study as well. I've listed their website here so that you can go and see. They have a lot of information about their study and chances at other collaborations as well if you're interested in that.
Thank you very much, Caitlin. Any questions, Doug, at that time?
Yes, we did have a question come in, and Christine is asking. So, based on all this, would you recommend routine meconium screening for all newborns across the country?
It's a very central question. To some extent, I'll answer it through my very close. So the question is, we showed you mostly studies done epidemiologically, not identifying necessarily the child in a positive manner. The question is, should we make it routine? Now, many people feel so. There are quite a strong voice against it too, for obvious ethical and ethical legal questions. And that will move us to my presentation. It will be short, but in a way it will either answer the question that Christine asked or open it up. Is maternal consent needed for testing? Clearly, here's a very powerful tool to tell us if the baby was exposed heavily to alcohol. Can you do it without maternal consent? Of course, all of you practicing clinical medicine and the public health people among you know that there is inconsistency here. Most neonatologists, if they think the baby was exposed to syphilis or suffer from syphilis, will go and test for it without permission. More and more so even with HIV, which was not something that you could have tested, say, 15, 20 years ago without maternal consent. It's also clear from what you heard that without testing for FAE, the baby will go lifelong with serious neurobehavioral issues without diagnosis. Needless to say, having at home probably a mother who is addicted to alcohol. So the question is, we are stuck here with this slide. We'll try something else. We brought this question to Bernard Dickens. Bernie Dickens, known to some of you, is a professor of law and ethics. He ran the REB at the University of Toronto for many years. He is a lawyer. And he actually was part of several commissions done by governments about fetal rights and fetal health and so on. And actually, this is from a paper that he published in the Journal of Fetal Alcohol Research 2 years ago, or a little bit more than 2 years ago. And I just want to his summary. None of these cases was ever brought to court in Canada, so we do not know what the judge or judges would say. But Bernard Dickens summarized, Meconium testing is done for health purposes, and of course not to obtain evidence for police purposes. He believed that it's legally okay to test it, even without consent for those reasons, kind of favoring fetal rights and other type of rights, such as women's rights. However, he continued to say the fact that meconium may lawfully be tested without a mother's consent raised the issue of whether it's ethical to employ this power by law. And he said not everything which is legal is also ethical, and whether mothers should at least be informed that this test will be conducted. Presently, much of the testing done clinically is when there is another authority involved, such as children aides. More and more so, neonatologists and pediatricians also send samples, and I cannot tell you that there is a consensus about that question. As to the question whether anyone should be tested, here is some of the answer, and I'm jumping some of my slides. A national discussion is still going on and should continue, whether we should be added to the global screening of newborns, the FASD, or the test of FAE meconium. Here is some examples. We now test for hypothyroidism by blood, heel prick blood. Hypothyroidism occurs in 1 in 4,000. We do it for PKU. It's 1 in 20,000. FASD, as you heard again and again, is 1 in 100. So the prevalence of it's basically the most common preventable cause of developmental delay in Canada and many other countries. So this begs the question, why not to do it? You may argue that unlike hypothyroidism and PKU, this is of course a labeling disease. It labels mom as addicted and so on. So it's not as simple. And clearly the answer is not as simple. So I cannot tell you that there is a consensus around the country, but many people say, unless you diagnose early or identify the baby that it has been exposed heavily, you're not likely to move forward like the case that Joey showed you, the first case we happen to be able to move forward. You will not mobilize help for him and neither for his mother. the mother, if she is still addicted, as happened in many of these cases, she is likely to give birth to another child that may be affected. So there is a very strong voice in the country to make it screening, but there is a as loud voice of people who say, be very careful. There are human rights clashes here. Of course, we are scientists and physicians, and this is the type of decision that I believe need to be done by society. Quite often this is done by lawyers and judges, but I think if I now involved in this field for about 14 years, there is more stronger voice. Unless we diagnose early, our interventions are not as effective. So clearly we should consider that without that, we are talking about a child that may go lifelong without knowing why he or she are developmentally delayed. That will allow us to identify them and intervene, which is a very powerful argument. So kind of in answering the question, I also showed you my small piece on the ethical debate, which has not yet been settled. Those of you who practice for quite some time may remember that we had a similar discussion about HIV, testing moms for HIV. The way the pendulum moved with the HIV is that now rather than opt-in, there is the opt-out. It's done in more and more jurisdiction on everyone, except if mom chooses to opt out. And some of my colleagues and ethicists suggest that that may be what we should do here too, doing it routine and allow opt-out. Joey mentioned that the saving or a cost of FASD in Canada is about presently estimated $1.2 to $1.5 million till the age of 65, which means for Canada, based on birth rate and 1%, we're talking $3 to $5 billion a year. So any attempt for secondary prevention is not just the right medical and public health move, it's also a financial, very strong health economic move. And that's kind of conclude my answer to the question, and maybe there are other questions.
All right. Well, there haven't been any other questions yet, but just to sort of go back to that whole discussion that you just laid out around the ethics, that there is one of those webinars that we did. It was actually an in-person meeting with a number of people, both by webinar and an in-person audience, focused specifically on that ethics question, where you mentioned Bernard Dickens and a number of other lawyers and clinical experts, et cetera, that really focused in on that ethical discussion. So I certainly encourage people to go back and take a look at that, because that discussion really got into the ethics of this issue, just as you pointed out some of the highlights, Dr. Koren.
Joey, want to add some points around this?
If I may, Doug, it's a very good question, and it often comes up as to whether or not we should be testing all babies. The important thing to recognize that we've established is that the disease is highly prevalent. The adverse outcomes to a large part are preventable. Have the tools to identify this early. The problem we have ethically is that you can't screen babies unless you have diagnostic services to refer them into, and unless you have support services available for mom. So when you ask the question of should we screen, we should only be screening everyone if you have somewhere to send moms that have babies that test positive, where they'll get additional support, much more comprehensive postnatal support. World Health Organization is pegging mental health issues at about 10 to 20% lifetime prevalence as one of the primary emerging causes of morbidity worldwide. And you can see in the studies I showed worldwide that alcohol consumption in pregnancy, this is not a first world problem alone. And public health messaging has helped that a lot. But we're identifying moms that who the healthcare system has failed up to this point of their lives. They've got an untreated alcohol use issue, and now they've got a child that they have to care for. The goal of screening from a healthcare standpoint is to make people's lives better and healthier. So when we think about whether or not every child should be screened, we have to think about, when we screen a child, are we going to be making their life and mom's life better by doing this test? And in our small pilot, we were able to do that because we had a very manageable situation and a very cooperative public health unit with resources that they had earmarked for just this type of thing. So the discussion is not just about the test. It's about, can we get the nurses, the counselors mobilized to give mom what she needs to get healthy and to care for her baby and to follow up this baby over the next 4 to 5 years until we can get them fully diagnosed.
I may go back, unless you tell me there are more questions, Doug, into the big picture. That several attempts now in Canada to answer the question, how many kids are affected by FASD, as a basis for clinic needs, screening needs, cost, public health, all the aspects of public health, indeed. However, very few kids every year in this country of ours are diagnosed. So even if we combine all the diagnostic cases, it's a huge underestimate of the real cases. Here we have a biological marker which is totally objective, multiplied by the fact that several studies have shown that about 40% of those heavily exposed will exhibit the spectrum of FASD. So 1% comes from the 3% that both Caitlin seem to go towards, both Joey in his PI study and in the GreyBruce study show. If the national rate will hover around the 3%, which kind of go towards, 40% of 3% is 1%, which means that really the estimate of 1% affected individuals is valid and concrete. And that will be important to know because it has so many verification and of course so much ramification to how we do and what we prevent. So we believe that even if it's not becoming a screening tool for the whole country right away, one may want to think how to incorporate it beyond just the epidemiological value. As I said, presently our laboratory is it's the only one in Canada to do this, but we have to remember that we do it now for children aides, for clinicians who are go forward to do it, but much more can be done, of course, very cautiously, while keeping human rights and mom's interest in that project. And trying to get to a Canadian consensus how it can be used. Again, to put it in context, Canada is the first nation to do it. We are ahead of the game, and that's largely because of the Public Health Agency of Canada. Although I don't want to mention all the names, I must mention Holly McKay, who has been with us in this long journey for more than 7 years, and many of her colleagues. The understanding that public health must really do much better for these affected kids with the most common cause of preventable handicap in young people. I think that's the end of what we had in mind, Doug. If there are more questions, we'll be happy to answer them.
Yeah, there are a few questions. A couple of people asked about the slides, and are the presenters able to share the slides for us to post up on the website?
For the most part, yes. We'll have to have a small consultation here because some of the work that Caitlin showed cannot be, because it's ongoing, as you saw, has not been published or presented, so we may jeopardize the validity of a report later.
Mm-hmm. Yeah, no, that absolutely. Yeah, so we will put on the Knowledge Exchange Network whatever it is that we can.
Absolutely.
We did have another question from Doug that came in, and he was asking about how much does the cost of meconium testing affect the ability to do universal screening? Is it a hindrance?
It's a very good question. I can tell you that now the province of Ontario is looking into it in the context of not all kids, but really high-risk kids based on several. Presently, it's done out of my research laboratory, so the cost is not really the industry cost that it can go when we do it in a larger scale. I don't believe it will be a very cheap cost because it needs very elaborated laboratory techniques. GCMS, we are moving into LCMS. These are not cheap. However, again, when you do a test, and even if it costs in the hundreds of dollars, you have to remember what it saves. Cost effectiveness will have to include. But it's an excellent question, and of course we are now, being in translational research mode, we are now exactly at that point. Presently, I can tell you that hospitals, children aides, and other authorities do pay for the test. So more and more people are convinced that this is an important test, but clearly, like any other testing that you make a screening, many other costs will have to be built in, such as counseling, and as Joey said, the clinic and so on. So clearly, it's not a very small question to answer, but we are on that road now.
Christina gave us a question. She's asking, what is the conversation regarding the need to have evidence of significant prenatal exposure to alcohol? And she goes on to ask, how much can we do to diagnose later if mom self-reports when there are issues with the child?
I can speak to that a little bit. Mom can self-report. So when I say evidence, I'm not talking about legal evidence. It's really information. The diagnosing clinician requires information about prenatal exposure history. But I can tell you from practice in our FASD clinic here at Sick Kids Hospital that most of the kids that are coming are coming at older ages, usually much older than 6. Giddy, what is it, about quite a lot at 10 or 12 years old, where they've had substantial school issues already, many of them not with their biological parents. So the nature of where the information comes from actually doesn't matter. So in a world where self-reporting is highly accurate, and studies have actually shown that self-reporting is very accurate in certain clinical contexts, like where the person has a long history with the healthcare provider and has already developed a relationship of trust. Self-report's highly accurate. The issue we're dealing with here is that is not the norm. So therefore we can't rely on it. So to answer the question, a mom self-reporting alcohol exposure doesn't require a laboratory test to establish that the baby was exposed. If she's self-reporting, that's the source of the information. But what we find in clinic is that most often the children that are experiencing problems are not with the biological parents, and that information is really not available.
Well, and as showed by the meta-analysis that Joey just mentioned, published several weeks ago from CAMH in Toronto, Dr. Popova is the leading author. She showed that the meconium is 2 to 3-fold more sensitive than maternal reporting, for obvious reasons known to all of us. But clearly, the question is well taken. A positive report by mom about problematic drinking is all we need. But that's very, very relatively rare and far between.
All right. Well, I think that's all we have for questions that have come in so far. So maybe we'll give our panel an opportunity for any last closing comments.
Yeah, we certainly hope that this was helpful for you in your practice, either public health or clinical or any other. Clearly, we have to identify FASD as a major public health issue in this country. And here is a very effective tool for screening that we should use more as we try to tackle the secondary disabilities and really improve the life of these families. Thank you very much all for participating.
All right. Well, thank you. Certainly, thank you to our panelists. It was excellent.
presentation. There were no questions because all of the speakers are providing so much clear information, and I couldn't agree more. That was a fantastic presentation, and certainly built on all of the previous work that we presented at these webinars. So thanks to our presenters for such a great doing such a great job, and thanks to everyone for attending. We're not done with our fetal alcohol spectrum disorder series, so there are a couple more coming up. You can always go to the cafc.org website and look under our CAFC Presents page. There's a calendar there that shows all of the times and dates of any upcoming webinars. So we hope to see you on the next ones. We usually do them at 11 a.m. Eastern Time, so hopefully we'll see you at the next webinar. All right, thanks everyone for coming, and we'll see you soon. Bye.